mechanical ventilation. So this week we're going to talk about ventilator setup and complications. And we'll just kind of delve right in. Again, if you guys have questions throughout, you can just kind of holler at me and I think I should be able to see when you chat. I just have to exit the share screen, but no big deal. So the ventilator, when you're setting up a ventilator, so at this point, we've talked about intubation. You've intubated your patient, you have them successfully intubated, you know that they're right, you're bagging them, and then maybe you're going to put them on a ventilator. Now, hopefully, as soon as you intubate a patient, you can get them up to the ICU. You can work with a good respiratory therapist or a pulmonologist that can help you set the ventilator. But that's not always the case. Sometimes, for whatever reason, you can't get the patient to the ICU, or you're going to be the most qualified person to set up the ventilator. And in some cases, and now like with COVID, we saw it. We have people that are intubated that might be stuck in the emergency department for prolonged periods of time. So having an understanding of the ventilator is really important as the ER doctor. A lot of times it's going to be on you to try to problem solve. So just kind of having an understanding. I strongly recommend that you go, and if you ever have time or you can, you take the ventilator that you use or that you have available to you, and you mess around with it a little bit. You talk to the person who normally does it. So here we have respiratory therapists. You talk to them, have them walk you through the different settings and see what you have available. So and you can change them. So when you're setting a ventilator, there's a few things you're going to look at. So you're going to pick the type of ventilation, the mode of ventilation, your tidal volume, and your inspiratory settings, your respiratory rate, your FiO2, and your peak. And that's the positive and expiratory pressure. So every time you set a ventilator, you're going to have to set all of these parameters. And then if you adjust, these are different things you can adjust. So probably the most complex would be the type of ventilation would be a volume controlled ventilation. So the different types of ventilation, most complex part of a ventilator. So the first one you can pick is volume controlled ventilation. And with that, what you're going to do is you're going to select a specific tidal volume. So based on your patient's ideal body weight, you're going to select the tidal volume, and then that amount of volume is going to be delivered with each breath. And so basically the volume is set and the pressure is variable so that it allows the patient to get as much of the volume as you want. So say you have a patient, you want them to get 400 milliliters tidal volume every breath. You're going to set that 400 specifically, and then they're going to use their own pressure to determine how much pressure they need on inhalation to get that much tidal volume. And the peak inspiratory pressure on the setting is going to vary depending on the airway resistance and the lung compliance. So that's what is your underlying lung disease, as well as like the size of your tube, if there is any swelling in the airway, things like that. But usually just the size of the tube, and then also the lung disease that you're dealing with. The next would be a pressure controlled ventilation. So this is kind of the opposite. So this, you're going to set the pressure. So you're going to put a specific pressure and inspiratory time. And so that you're just going to allow that much pressure. So that when the breath will be terminated when that inspiratory time is reached. So you'll say the person has 8 seconds, to take a breath. Inspiratory pressure is guaranteed, and tidal volume is dependent on the airway resistance. So this one, you're going to say, well, we're giving this much pressure, and then that volume can vary. The pressure controlled can be a little tricky because for some people, they'll end up taking in too much. So their tidal volume becomes too much. So I would typically go with a volume controlled, so you can set that and have a little more control. For a lot of disease processes like asthma, COPD, the pressure controlled ventilation can be dangerous because if they're getting too much tidal volume, then you're putting in too much oxygen into the lungs, you're building pressure, and then that can lead to problems. There's also pressure support. So that requires an intact respiratory drive. So you would select the inspiratory pressure you want. The patient will initiate the breath, and the pressure quickly rises the pressure and is maintained throughout the entire inspiratory phase. And tidal volume is also dependent on lung compliance or inspiratory effort. Pressure support is something that it's a setting that can be used like in the ICU when you're trying to wean mechanical ventilation and kind of getting an idea how much tidal volume can your patient take with just a little bit of pressure support. So you can set the pressure support just enough to offset the resistance of the endotracheal tube and the large device of the ventilator. So you set just enough to offset that and see how they're breathing. And that can determine if they're ready to be weaned off a ventilator. In the ICU or in the ER, you're typically not going to do a pressure support setting because the patient is still heavily sedated and or paralyzed, and they're not going to be at a place where they can breathe on their own. So for me, I would go with a volume controlled ventilation typically. So deciding what tidal volume you want based on the ideal body weight, and then putting that setting in. The different modes of ventilation, that would be a little bit different. So with that, you're going to have assist control. The two main types are assist control and then SIMV, or synchronized intermittent mandatory ventilation. So assist control, again, is more common from the ER, but some people would go with SIMD. So assist control, that like we kind of said is a volume supported type of ventilation. You preset the tidal volume, and they're going to, each breath they're going to take, or each breath that you give them based on the respiratory rate, they're going to get that much tidal volume. So say you say, I want my patient to breathe 20 breaths per minute. I want them to get 400 mLs of oxygen with each breath. That's what they'll get with assist control. And the pressure is going to vary depending on the patient's lung disease and the resistance of the tube and the ventilator. The SIMV is going to be a little different. So that's a guaranteed set volume and a pressure at a set rate. So you're going to kind of give them a volume and a pressure. So they could breathe spontaneously, but they don't get that volume or pressure with their additional breaths. They're only getting that set volume and pressure when you say. So if you set it at 20, and at 20, you want them to get a specific volume, specific pressure. So all they're going to get in every extra breath, they don't get any support from the ventilator. Whereas assist control, if they're breathing over the vent, they will get some additional pressure and additional support. So, a lot of disease processes in the ER, that initial, and keep it simple, assist control. I set it at assist control almost every time. These other ones, is good to know if your patient looks very uncomfortable. We'll talk about that a little bit, or you're having difficulty with oxygenating them. They're hypoxic or other reasons, and you can think about these other settings. If you start to have, more advanced, you can play around depending on the exact disease process, but that gets pretty complicated. Continuous positive pressure is going to act like CPAP, just like it would without the mechanical ventilator. So with this one, the patient would have to be breathing on their own, and they would get just this continuous positive pressure, and each breath they'd get additional pressure. But this requires a lot of patient cooperation. The patient has to be pretty with it, which isn't always, it's just not very common because it's uncomfortable. So these patients should be sedated. So the next part of the setup will be your tidal volume. And like we talked about, if you're doing assist control, then you would need to select a volume. So if somebody has a non-pulmonary issue, they're being intubated for, say, altered mental status, or they have a low GCS, you need to do a procedure on them, then you can set them with an 8 to 10 cc's, or milliliters per kilogram of their ideal body weight. So remember, it's not their actual body weight, it's their ideal body weight, and that's based on their height. And there are easy ways to look that up and calculate it. And there's actually in the most ventilators, it'll just ask for the patient's height and it'll automatically give you the ideal body weight. But if anybody has a pulmonary disease, so you're intubating them for COPD, asthma, anything really beside the main reasons why we intubate patients, to be honest, you're going to give them lung protective settings. and those would be setting it at 6 cc's per kilogram of body weight. Easier to remember. If you don't want to remember a lot of things because it's tricky, just start at 6 for everybody. If you need to go up and you can go up, that's fine. But I would start at 6 cc's per kilogram ideal body weight for everybody. It's just more simple. You're going to protect them. And for most of the time, we're intubating people for respiratory issues. Next will be a respiratory rate. So the respiratory rate, you're going to kind of look and see what your desired minute ventilation would be. So what you want them to be at. You're typically going to set these patients at any patient at 12 to 15 breaths per minute. Now, where this would vary was if you have a patient that is severely tachypnic before you intubate them, you're going to want to try to match that respiratory rate as best as you can. So say you have a patient that is in diabetic ketoacidosis, they have a very low pH and they are breathing really fast to help them blow CO2 off to improve their acidosis. Well, it's imperative that you maintain that high respiratory rate. Otherwise, your patient is going to start to maintain that CO2 because their kidneys aren't going to have time to excrete it as fast as they're breathing. So they're going to build up CO2, and that can be detrimental for these patients. So kind of try to watch what your patient is doing. If they are breathing really fast, it may be for a reason, check their pH, check their labs, and try to think about why you're intubating them and what's going to happen afterwards. So you can set the rate high, and then you can always titrate down as you need to or up. So the respiratory rate's actually pretty easy thing to manipulate and change based on blood gases that you're getting and what you see from your patient. A patient that has COPD, sometimes a low respiratory rate is better because if you give them a low respiratory rate, it's a good way to give them a long time to exhale and make sure that they're not building up CO2 in their lungs. So they have a long expiratory phase because they have low lung compliance. And when you have low lung compliance, your lungs aren't as elastic, so you can't bounce back, get rid of that CO2 as fast. So you need a long time to exhale that CO2. And decreasing the respiratory rate is an easy way to do that. The next setting you're going to look at is going to be your FiO2 or oxygen saturation. Something to always keep in mind, some ER rooms, the oxygen that's on the wall is not titratable. So no matter if you titrate the oxygen on your machine, it's always going to be 100%. And that's okay from the emergency standpoint, like the emergency department. But in general, you're going to want to titrate down as much as possible to get your patient with a pulse ox of 92 to 98%. And that minimizes the release of reactive oxygen species and things that can cause damage. So having an oxygen of 100% can sometimes cause damage. So we don't love to see that. I want it a little bit lower, like 92 to 98. But it's a question to ask is see what your walls are. Some rooms, it's like just the trauma bays, the oxygen is titratable for the ventilator. And hopefully you can have somebody help you with that, but you can titrate that down. And then finally, you're going to set the positive end expiratory pressure or PEEP. Now, PEEP is what it is for is to help maintain alveolar recruitment. So adding that end expiratory pressure, so a baseline pressure, helps keep the alveoli inflated. So they're inflated. When they're inflated, it allows for gas exchange, and that allows the patient to have improved oxygenation. PEEP, you have to be careful. You can't go crazy with it because it can decrease cardiac output. If you're increasing if you have constant PEEP at really high numbers, it's causing an increase in intrathoracic pressure, which decreases blood flowing back to the heart and then flowing to the rest of the body, including the lungs. Typically, every patient's going to get at least some PEEP, a PEEP of 5, and then you can increase it though. And with ARDS, you're going to want to go up a little bit more on your PEEP. And then there's a really good chart that I'll show you in a little later about, if you're titrating FiO2, it should be in relation to your PEEP as well. So a couple of things to know with the ventilator when you're setting up the ventilator. One is plateau pressure. So these are both the indicators that you'll be able to see on the ventilator. You can just ask your respiratory therapist. But again, like I said, you should look at the ventilator and kind of mess with it, have somebody show you how it works and where all these things are, so you could find it if you wanted to. So the plateau pressure is going to be something that you measure. So it's basically, they'll do a hold on the ventilator. It's an inspiratory pause. It's performed for 0.5 to 1 second. The machine does it automatically in most cases. So the ventilator, every ventilator I've seen, there's a button, it helps you allowed to do it. It's going to be a reflection of the alveolar pressure. And so that's the pressure required to inflate the lungs. You don't want to see this high. If your plateau pressures are too high, that can result in significant lung damage, can increase your risk for developing pneumothoraces. It can increase your risk for having decreased cardiac output. So that would make your patient hypotensive. There's a lot of things that can go wrong. So you want to watch your plateau pressure. Plateau pressure is a really good thing to measure if you're intubating, and like keep an eye on if you're intubating asthmatics. If you've heard, like, it can be very dangerous to intubate asthmatics, because what happens is they're getting this oxygen in through the ventilator, but they have a hard time getting it out because they have decreased lung compliance. Their lungs are not elastic. So they can't exhale. So they get this buildup of oxygen inside the lungs. And then that oxygen goes to CO2. It builds up, increases pressure, and that can increase that plateau pressure. So keep an eye on it. If you do intubate these patients, and you can watch, as long as you're staying below 30, you're probably not going to get that damage to the lungs. But if it goes above 30, you have to figure out how to decrease that plateau pressure. The other thing that you could look at is the peak inspiratory pressure, and that's the pressure that's required to move air through the endotracheal tube, airway, and alveoli. So basically, how much pressure does it take to get through all the extra stuff, to get through the resistance of our airway? And the difference between the peak and plateau pressure is resistance, so the ET tube and the airways. So peak inspiratory pressure, another thing to measure. For me, it's not as imperative as the plateau pressure. Plateau pressure, really something is good to keep a close eye on when you're intubating patients with chronic lung disease, especially obstructive lung disease. So for me, part of the ventilator setup is sedation. So if you don't get anything else from this lecture, you want to go and you talk to your respiratory therapist and have them do all the settings, that's fine. But it is up to you to do sedation. It increases the risk for complication, for intubation, for mechanical ventilation, to have a patient that's not sedated. These people have prolonged ICU stays. They have long-term complications. A lot of badness if they are intubated. All the studies show if you're intubated without meds. So please try to put your patients on sedation as quickly as possible. So the complications specifically, you can get somebody that's agitated, so that can make them tachycardic. It can increase their blood pressure. They can start biting the tube, which if you bite the tube, then you're not getting good blood flow. You're increasing resistance to oxygen coming in. You can start gagging. You can start coughing. And then for all those things, you have decreased delivery of oxygen. You also have a risk of dislodging your tube. So you did all that hard work to get them intubated, and then they might just pull their tube, or all the coughing and gagging the tube might pop out. So there's a lot of options for sedation. It's really good to get on the same page as your ICU team. It's great to do all these things, but if you're gonna send the patient to the ICU and they're gonna immediately change the sedation, sometimes it's worth just doing whatever the ICU team likes to do, or wherever your patient is going. Easiest, probably most commonly used still, is propofol. So propofol is easy because it's easily titratable. You can turn it off super fast. You turn it off for whatever reason, and it stops affecting the patient within a couple of minutes. It's really inexpensive. It's pretty readily available, at least here in the United States. It can decrease your seizure threshold. Some risks of it is it can cause hypotension and there's no pain control. So if you're doing propofol, you may have to do something for pain in addition. So like a fentanyl push. Don't use fentanyl boluses, fentanyl drips. Fentanyl drips have been shown to increase ICU delirium. They can cause hypotension. They can suppress our immune system with adrenal suppression. So no fentanyl drips, but you can use fentanyl boluses in addition to the propofol. Next would be ketamine. So you can use ketamine. Its benefits for putting somebody on a ketamine drip is it's less likely to cause hypotension. It can be used for induction and sedation. So that's kind of nice. You can just give the patient, 1 mg or to 2 mgs per kg for your initial intubation, then just put them immediately on the drip. Or you can even hang the ketamine and then bolus them from the drip that you already have ready, and then they're immediately on the drip. It has a lot of potential to decrease pain. So when you use ketamine, you usually only have to use one agent, which is nice. Another one that is used would be Versed. So Versed's great if you have alcohol withdrawal, because it's great for alcohol withdrawal. So if you're intubating a patient for that reason, it might be a good option. And then decreases seizure threshold. So somebody with status epilepticus may consider it Versed. The major downside to Versed is that it can cause some hemodynamic instability, so hypotension, bradycardia, and it can also really increase your risk of delirium and ICU delirium, especially with prolonged drips. That's less likely for your alcoholics because their benzo receptors are so shot from the alcohol use. They usually tolerate it okay, but in other people, especially elderly people. So, Versed's not one I would use on an older person. For pain control, you can use ketamine, fentanyl. You could also use morphine or Dilaudid if you wanted. Those just kind of whatever you want. But if the patient looks uncomfortable, then think about giving them something for pain, and watch your patient. Even if they're intubated and they can't tell you, their vital signs often tell you if they're uncomfortable, if they're becoming hypertensive, if they're tachycardic, if they're diaphoretic, like sweating. You can look and see signs that somebody is uncomfortable. So complications from intubation, they are many, but important. We're just going to talk about a few of the really key ones. So biggest complication is hypoxia. That's during the intubation and while somebody is on the ventilator. You're hoping that they're not, but you have to look. So that is a great, easy one to notice. Somebody's hypoxic. So you can watch the pulse ox very easily. Are they hypoxic? Is their oxygen dropping? Get a good pulse ox if you have a patient that's intubated, something that's reliable, that's not coming off. You have to have a good waveform and look for that. Another complication would be hypotension. And we talked about that a little bit, and it kind of goes along with that second one. But when you're intubating a patient, you are going to increase the intrathoracic pressure because you're putting oxygen in to the chest, which increases the pressure. That can decrease how much venous return you have to the heart. And so then your cardiac output will decrease, and that can make you hypotensive. And you just have to watch that. So you're watching your patient's blood pressure. You have an increased risk of pneumonia. That tends to be more long-term. And it's the length that somebody is on a ventilator, with each day that they're on the ventilator, their risk of developing pneumonia or lung complications will increase. And then how the intubation goes. So if somebody has aspirated, if you had multiple attempts at intubation, those are all going to increase your risk of a ventilator-associated pneumonia. Along with those, there's problems with the endotracheal tube itself. You can get mucus plugging, so the tube can become full of mucus. Pretty easy one to address. And, a lot of times your respiratory therapist is going to be doing prophylactic suctioning on these patients. The ventilator will usually warn you and give you a warning that there's an obstruction in the tube. So just look for that. The tube can become dislodged, so that tube can come out. It can kink if the person is biting the tube, or sometimes during positioning. I've seen it where like it'll kink on the side of the mouth, various reasons it will kink. And then the cuff can rupture. It's more likely to happen during the actual intubation process. But if you inflate the cuff too much, sometimes there's too much pressure in there, it can cause it to pop. Or if you have an older endotracheal tube, maybe it's been sitting in your cabinet for a long time, then it might rupture as well. So a good mnemonic, and I know mnemonics are probably harder for you because it's your second language, but if it's helpful for you to remember, you can remember DOPE or DOPE, a dislodged or displaced tube, obstruction of the tube. So check the ET tube for mucus plugs, kinking, vent, kind of those things, pneumothorax, or if there's an equipment malfunction. And these are to see, is there hypoxia or is your patient deteriorating? Are they becoming hypotensive? Are they really tachycardic? Do they look extremely uncomfortable? Those are the things you're going to look for. You're going to watch out for. Dislodged tube, obstruction of the tube, pneumothorax, equipment malfunction. So these are patients that usually get one as close of nursing as you can afford in the emergency department, I'll say. And they should bring it to your attention if your patient's not doing well. So for me, what do I do? So say I see these things, the patient's becoming hypoxic, or I go through that DOPE mnemonic, but what are my first actions? I usually will check sedation first because it's so easy. If I see the patient is a little hypoxic, they're maybe kinking or biting the tube, do we need to increase sedation? Or if they're hypotensive and they're on propofol, do we need to turn down the sedation a little bit? That's an easy thing to do. And then managing those other things, like, are they hypotensive because they're septic and you need to put them on a pressor or give them more fluids? Making sure those other things are taken care of. And then I would go to the ventilator. So I would maybe decrease the tidal volumes a little bit, and that would decrease the intrathoracic pressure. So that's an easy fix as well. You could see what tidal volume the patient's been taking in, try to take that down. Kind of along those lines, you can decrease minute ventilation. So that might mean decreasing their respiratory rate. So if they're breathing too fast and their tidal volumes are too high, maybe they're just getting too much oxygen. So you can try turning both of those things down. So respiratory rate and or tidal volume. And in that case, you could always get a VBG or an ABG to see as well. If your oxygen is really high on your ABG or VBG, might indicate that they could do with a little less. You can try repositioning your patient. So if they're hypoxic, this was really common with our COVID patients. They were hypoxic on the ventilators, but putting them in a different position. So laying them on their side. If somebody has a big effusion or fluid on their right side, try putting them with the right side down. And that way that they're mostly ventilating off their left side. Just trying different positions as best as you can, making sure that tube is secure. And for sure the head of the bed up as long as you can. There's no traumatic injury involved. Other things you can do to check if the immediate things like at the bedside aren't working, you can get the ultrasound out, start ultrasounding the lungs, see if you see lungs sliding, or get a chest x-ray. If chest x-ray is nice because it gives you, hey, is there a pneumothorax? Are you developing ARDS, or is the tube in the proper position? So that chest x-ray can be multifactorial. Even if you've had a chest x-ray that showed everything looked okay immediately after, if things are changing, your patient is deteriorating, it's okay to get a second x-ray. Talk to your respiratory therapist, see if they have suggestions, and you can probably talk to a pulmonologist or an ICU doctor as well. If you have high suspicion for a leak, like there's a malfunction of the tube itself or the cuff, and sometimes you can hear that. You can check for that if you notice like on the bubble that's on the side of it is deflated, those things, then you could consider a tube exchange. These, try to avoid that because every time you're going in there, you're risking complication, that tube being dislodged. But if you have to, you have to. Typically, these can be done fairly easily over a bougie. So you can put the bougie over the tube, make sure that you're in the proper position, take the bougie out, and then put the second tube on. So that kind of is, I mean, it's a lot. It's so much. And honestly, I am constantly reviewing ventilators. I always try to ask the respiratory therapist. Every time I intubate a patient, I look at the settings again. I look at it because it's so hard and complicated. If you have a good pulmonologist that you trust or ICU doctor, you can ask them to talk you through it. And this is one where, you know, hopefully at some point I could get to Vietnam, we could look at it together, but it's something that's really nice to do in person with the machine in front of you so you can see the different settings. So if you have the ability, I'd really recommend doing that. So any questions so far, just regarding all that breadth of information? And I will make sure you guys get emailed out probably right after this lecture, all of these, so you'll have the slides and you can look through them to process the information a little better. But any questions? Okay, well, we will move on to the questions then. So here is your first patient. You have a 24, and you can answer in the chat, and then after a couple of minutes of the chat, then I'll have to exit the screen. I'll just check the chat box, and then we'll talk about the answer. So 24-year-old male presented to the emergency department with acute asthma exacerbation that was refractory to optimal treatment. A few minutes after intubation, the patient nurse tells you that the patient is waking up and fighting the vent. Your best initial course of action is to A, paralyze the patient with cistercurium to be sure that he synchronizes the vent. B, give the patient a bolus of propofol and then place him on a propofol drip. C, give a one-time dose of fentanyl, 100 milligrams. D, paralyze the patient with succinylcholine to be sure that he synchronizes the vent. Or E, check a stat metabolic panel to make sure that he is not hyperkalemic.
In my opinion, I would choose the answer B, give the pulse propofol and then propofol drip. I'm not sure, but I will choose B.
Yeah, I totally agree. I would as well. So, yeah, this patient, he is an asthmatic. So we talked about their high risk when you intubate them. You want to make sure that it's optimal. If this guy is biting down on the tube, then you're decreasing resistance, you're decreasing how much oxygen he can exhale, and you're increasing the risk for him having increased pressure, having a pneumothorax, then really deteriorating. So you want to make sure this guy is comfortable, this asthmatic that's having to be intubated. So for him, I'd give him a bolus of propofol here and then put him on a drip. And the nice part is a lot of times asthmatics, when you intubate them, they're usually either hypertensive or at least normotensive. So you should have room to bolus and give plenty of propofol and have good sedation. You would want to do something for pain, but at this point, he's going to need more than the fentanyl to properly sedate him initially in this case. So yeah, great job. So next question. You are working in the ED when you are called to the room of an ICU patient who is boarding in the ED. The patient is intubated and a nurse is at the bedside. The nurse informs you that the patient has desaturated to the 80s. The waveform on the ventilator shows high pressure with an elevated ratio of peak pressure to plateau pressure. So that plateau pressure we talked about is high. Which of the following is the most likely cause of the patient's decompensation? A, ARDS, B, endotracheal tube obstruction, C, pneumothorax, or D, volume overload? And you guys can answer too in the chat. This one is tough. This is a
Thúy Ngọc, anh cho thêm xét nghiệm với thuốc rồi nha, cho người nhà em á. Ừ.
I think the answer is C. Sorry, could you hear me?
Yeah, I can hear you.
Yeah, I think the answer is C. I'm not between B and C, but I will choose C.
Yeah, I think I'm with you. I would be between B and C as well. In this one, it does they give you B, endotracheal tube obstruction, and I agree that it could kind of be either in pneumothorax because you will get an elevated plateau pressure and peak pressure with a pneumothorax. I think the main reason on this one is that it's just high pressure. They're not giving you that the patient has. Sorry, I'm just going to. They're not giving you that this patient has like just breath sounds on one side. They're not kind of indicating that in the question stem. You will see that increase in plateau pressure in the pneumothorax, but more likely you're going to have an endotracheal tube obstruction. Something's obstructed, so it's causing that greatly increase in plateau pressure and peak pressure. If you have a pneumothorax, I think part of what happens is sometimes the pressure doesn't go up as high, and that's because you only have increased pressure on one side. So the pressure might be the same overall because even though it's going up on one side, you have no pressure on the other side. So the ventilator is going to read almost the same pressure, just a little bit higher. Whereas when the tube is obstructed, there's that pressure inside the lungs just keeps building and building and building on both sides. Once it builds so much, you might get a pneumothorax, and then the pneumothorax would actually allow there'd be some air leak, and then that one side would be collapsed. So in this case, it's endotracheal tube obstruction. If I was answering this question on like a board exam, I am with you. I don't know if I would have picked that. This was one from a question bank, not one that I wrote myself, and I might have put in pneumothorax myself as well. So I'm with you. So next question. 30 minutes after a 35-year-old female presents to the ED with severe asthma exacerbation, you intubate her because she is showing signs of fatigue and ventilatory failure. You use ketamine and succinylcholine and pass the endotracheal tube through the vocal cords without difficulty. A colleague who is assisting you aggressively bags the patient until the patient is placed on a ventilator. 30 seconds after intubation, the nurse reports that the pressure has dropped to 93/46. Her blood pressure before intubation was 138/90. The patient has an 18-gauge peripheral IV. Trachea appears in the midline. What's your best course of action? A, ask the nurse to place a second large bore IV and immediately place 2 liters of IV fluids. B, extubate the patient and deliver breaths using bag mask. C, disconnect the ventilator, but keep the endotracheal tube in place and allow the patient to exhale. D, ask the nurse to start a dopamine drip. Or E, perform immediate needle thoracostomy. Anybody want to give this one a shot?
It's difficult to me, but I will choose A. I will give the patient with 2 liters of the of fluid. Yeah, but normally I just give 1 liter of fluid. Yeah.
Mm-hmm. Yeah, I think, you're right with the like 1 liter fluid. So this one is tricky. There's a lot in the question stem to kind of delve through and look at. So, if we kind of go through it stepwise. So she's being intubated for asthma. So theoretically, she might need fluids because when you're breathing fast, you lose some fluid through your respiratory, that condensation. So you do become dehydrated. You might need fluids, but like you said, would you need 2 liters of fluids right away? Maybe not. When it kind of says it, so her blood pressure was fine. It dropped very quickly. So that wasn't like her blood pressure was soft or she was kind of slowly going down in blood pressure. It dropped very quickly during intubation. I think the key to this question stem is it's telling you that she was being bagged very quickly. So what that means is she had the tube and they were bagging her really quickly. So maybe giving her too much oxygen. When you bag quickly, what happens is you don't allow enough time for the patient to properly exhale. So you're putting oxygen in, but you're not allowing any time to let that CO2 leave the lungs. So in this patient that has an obstructive issue like asthma, just getting too much oxygen in, not exhaling, so you're just making the problem worse. So on her, you're increasing that intrathoracic pressure by giving oxygen, giving oxygen, giving oxygen. So the best course would, in this patient, be to disconnect that ventilator. So you take them off the ventilator and allow for an exhalation. A lot of times when you do this, you'll be able to hear the patient just all this air release. If it's not releasing, you can even kind of push down on the patient's chest, and that allows for the patient to really exhale. Usually once you do that, the blood pressure will go back up because you're decreasing the pressure in the chest, which increases how much blood can flow back to the heart, and that blood to get pumped through the heart back out to the vasculature and then increase the patient's blood pressure. So in this one, you would disconnect the ventilator. So if you see somebody's blood pressure rapidly drop, 2 things you're going to worry about is rapid increase in intrathoracic pressure from overbagging or too high of a respiratory rate, not enough time for exhalation. Or you can see it with a pneumothorax, and that's because you're putting so much pressure on the heart, you can't get blood back, can't get blood out. But in the case of a pneumothorax, so like say for answer E, the needle thoracostomy, if it was a needle, you would see this would be a tension pneumothorax. In order to decrease the blood pressure, you have to have a tension pneumothorax, which would cause a shift of the trachea from the midline, which is saying your trachea is in the midline. So in this question, it's kind of hinting to you, probably not a pneumothorax because your trachea is midline. So, when you have a patient on the ventilator, just constantly going through, making sure that everything's good and their vital signs are fine. If not, you're checking those things. You're going through what we talked about. But, along what you said, I would at the same time, you could easily do 1 liter of fluids. Most asthmatics getting intubated, they're on a sedation. Fluids probably not going to hurt that patient either. So next question. So 67-year-old female presents in acute respiratory distress. She endorses dysuria and back pain for 3 days, which she was hoping would get better on its own. The shortness of breath began today with acute worsening over the past few hours. She denies cough. Her vital signs of blood pressure is 96/57. Her heart rate is 121. Her respiratory rate is 38, so very fast. Her temperature is at 101.2, and she's 88% on 15 liters nasal cannula, which was put on immediately by the nurse because she was so hypoxic. She is speaking in just 3 to 4 word sentences. There is no jugular venous distension, so no JVD, no pitting edema in her legs. you get a portable chest x-ray and it is shown in the picture. So which is the most likely disease process here? A, pneumonia, B, acute respiratory distress syndrome, or ARDS, C, acute decompensated congestive heart failure, or D, alveolar hemorrhage.
I think that the answer A is in pneumonia. Maybe from the urinary tract infection and then she get the pneumonia follow it.
So yeah, it definitely could be because she's febrile, she's hypoxic. So yeah, but in this case, so that chest x-ray, so we didn't talk about it too much this block, but we'll talk, I'm sure I'm going to talk to them and you'll hopefully hear more about it, or it's just so much, but it's usually this x-ray is pretty indicative of acute respiratory distress syndrome. So that is going to be it's a non-cardiogenic pulmonary edema is the other. So in this case, this x-ray isn't going to indicate either a pulmonary edema. Usually if it's a pneumonia, it's going to be more of a consolidation. So you're going to have it be more unilateral, so one-sided, not often going to be bilateral like it is in this case, and it's going to be more discrete, so more in one section of the lungs if you're looking for pneumonia. This patient has diffuse involvement, so all of the lungs are involved, the apex of the lungs to the base of the lungs, it's all involved. The other thing that makes it more kind of pinning you towards this acute respiratory distress syndrome is how rapid the onset was. So she was having urinary symptoms, so she probably became septic, and that's what led to the ARDS. So she was septic, but if you look, the respiratory symptoms only really started a few hours before she came in. So this developed very quickly. Acute respiratory distress syndrome, ARDS, is going to come on extremely quickly. So it's an inflammatory lung condition characterized by, like we said, non-cardiogenic pulmonary edema with diffuse consolidation and profound hypoxia. There's kind of a spectrum. How you're going to say how severe it is by looking at the ratio of arterial oxygen to the fractured fraction of inspired oxygen. So you're going to get an ABG. This is one case where you cannot get a venous blood gas. You need an arterial blood gas to get the PaO2 and from the blood gas, and then you're going to look at their FiO2, so the oxygen saturation, and then you're going to get the ratio. If it's less than 300, this indicates that acute respiratory distress syndrome. We kind of talked about it here, and it's lumped into this because this patient is septic and got it. Most patients that develop ARDS, they are intubated patients. They have another pulmonary disease process that has led them to getting intubated. They're on a ventilator, but they have a rapid decompensation. So if you have a patient that's been intubated for sepsis, for something else, and they all of a sudden become very hypoxic, it's another reason to get a repeat chest x-ray, because it might end up being this acute respiratory distress syndrome. When you see that, you're going to look like they have this big pulmonary consolidations all over their lungs. It's usually fluid, and then you look, but you don't see fluid other places. You don't see they don't have splenomegaly, so they don't have a enlarged liver. They don't have peripheral edema like you would if it was coming from your heart. It's just the lungs, and you get this big fluid buildup in the lungs. It usually happens because of some inflammation, and then there's leaking of the capillaries. So the capillaries within the lungs leak out and the fluid collects in the lungs. This can be, there's a high likelihood of mortality and morbidity when patients develop acute respiratory distress syndrome, so ARDS. And when they do, so like this lady, every time she would need to intubate her, they are going to decline. And it's really hard to get the patient because you can't really give them a ton of fluid. It makes it worse. So you have to put them on a pressor. You need to give them some help with pressure to increase the size of their alveoli so that they can have better gas exchange, and that helps their hypoxia as well. So these patients, if they're not intubated, need to be intubated. They're already on a ventilator, you're going to need to adjust your ventilator settings to make sure that they're optimized. And we'll talk about that a little bit, hints on after the next question. And this is a tough one. And, I'm kind of using this question so we could talk about ARDS and hit on this subject. So an intubated patient is signed out to you pending admission to the intensive care unit. The patient is hypoxic despite being on 100% oxygen. You suspect that the patient is developing acute respiratory distress syndrome. What ventilator strategies should be followed? A, avoidance of PEEP. B, a goal PaO2 of 55 to 80 mmHg, so pressure. C, goal tidal volume of 10 ml per kilogram of ideal body weight, or C, initial tidal volume of 4 milliliters per kilogram of ideal body weight. And I'm going to help you on this one because we haven't talked about it, but I just want you to see. So when somebody has ARDS, so acute respiratory distress syndrome, you want them to you're going to set the ventilator with a goal of their PaO2. So remember, PaO2 is found on an arterial blood gas. You get an arterial blood gas. It's going to give you that PaO2 value. You want to make sure that it's between 55 and 80 for your value, anywhere between 55 and 80. Below that, then your patient is likely hypoxic. They're not getting enough oxygen. Above that, you're starting to cause damage and you can worsen the disease process as well. So between 55 and 80. In order to do that, there's something called ARDS-net, which is a really good set of guidelines. If you have a patient, you're suspicious for ARDS, that acute respiratory distress syndrome, or even they have a serious lung condition, they have severe lung disease, severe COPD, emphysema, you can follow ARDS-net on your titration of ventilation and even when you're initiating your ventilator setup. So you want them to have that. So first, you're going to look at what's your goal, and then you're going to go based on that. So your goal is that PaO2 of 55 to 80. That translates in on oxygen or a pulse ox of 88 to 95%. So if you don't have arterial blood gas, it's okay. It's a little less accurate, but you can use their pulse ox. So 88 to 95%. Below that, they're hypoxic. Above that, you can cause lung damage as well. So you're going to match, you're going to look at their FiO2, which is kind of down there. You'll see it in the chart, and you match it. So if you're going up on their oxygen, so by 0.3, that's 30% oxygen. So 0.3 is 30%, 0.4 is 40%. So that's how much oxygen you're titrating, giving your patient. If you're going up and you're needing to go up because your patient is still hypoxic, your patient with ARDS is still hypoxic, and you need to titrate your oxygen up, make sure you also titrate up your PEEP, so that positive and expiratory pressure. If you're ever like in doubt, you can always look it up. And remember, when you're doing these patients, if they have ARDS, they haven't been intubated, or if they've already been intubated, your optimal goal tidal volume is going to be 6 to 8 milliliters per kilogram. Make it easy on yourself. Just remember 6. 6 milliliters per kilogram is the ideal setting for ARDS or anybody with severe lung disease. So remember 6 mLs per kilogram. You want their oxygen between 88 and 95%. This PowerPoint will be available to you. So kind of those other settings you can look at. But if you're going to remember anything, you're going to tell your respiratory therapist anything from it. Low 6 mLs per kilogram. And then there's oxygen titration. And I want you to make sure that you have your patients sedated. So those are the key, really important things from this lecture when you're intubating your patient and after they've been intubated and they're on a ventilator. And that is kind of it. It's a lot of information. I get it. So please, if you look at it or you look at the PowerPoint and you decide you have any questions at that point, like anything comes up, like I always say, if you have a case and you want to tell me about it or go through it, you can always email me questions. But otherwise, that's it. Everybody good? Thanks. Any questions? All right. Well, it was a great block, and I will email you out those PowerPoints right now. Not just that way you have them for your own. If you need to go through them again for any reason or for later, then you have them. And I'll see you in a few months. Actually, not till March now because I just traded with somebody. That's going to be, luckily for you, in February. You're going to have some in-person education, which would be great. So, yeah. Well, thank you guys. Hope you have a good day.
Thank you and see you later.
Thanks. Yeah.
Yeah.
Bye. Have a good day. Bye. Bye.